I'm Zulfiqar Ali. I'm consultant oncologist from Glenclure Hospital. Thank you for inviting me for this interesting talk on castrate-resistant prostate cancer, because after a long duration of time, in the coming days, there are a lot of new drugs which is coming up, and they are in the pipeline as well. So what the future stands for them, and we discuss all those. So first of all, before going into those related to the drugs, about a natural history of the castrate-resistant prostate cancer. It's about 4 years, and it varies from patient to patient, and it starts from non-metastatic disease and then to asymptomatic metastatic and then symptomatic disease, and this again varies from patient to patient. There are few evolving terms over the time which we have known for last many years. The first term which we know was the androgen-independent prostate cancer, which was technically incorrect because these patients used to respond to the hormone treatment. Then the next term came up, hormone refractory, but still again it was incorrect because the patient was responding to the hormone treatment. And now currently we're using the castration or resistant prostate cancer. It is okay, but I think politically or from patient perspectively, it is not acceptable. And what the future I think is proposed or politically we think is the correct version is the endocrine resistant, which probably I think will be acceptable more to the patient as well. This is just a brief cartoon about the androgen-resistant prostate cancer. This is a normal pattern on the left side. But what happens is when there's androgen-resistant, there are different mechanisms involved in the androgen-resistant. One is there's an amplified androgen receptor. When the receptors are more, even the small amount of testosterone will lead to increased proliferation and division and increased progression of the disease. Another theory about that one is there's a mutated androgen receptor, and if the androgen receptor is mutated, some other cytokines and growth factors act on it, that can lead to the activation and proliferation. Another about is there's a loss of P10, which is very, very important, as as I will show you in the coming slide, that this inhibits the PI3K, and which ultimately leads to conversion of AKT, and this leads to increased overexpression of BCL2, and BCL2 leads to another pathways which are free from the androgen and lead to stimulation of the growth of the prostate. And there's some neuroendocrine cell-like or neuropeptides, they also stimulate, and they are independent of the testosterone. This is just a brief cartoon about the signaling axis, from pituitary, starting from hypothalamus to pituitary, and then testosterone glands, and where the different drugs are acting on those. Now, just briefly about the current standard of the care, what we are doing nowadays for the prostate cancer when it becomes castrate resistant. If it is hormone naive and have a metastatic disease, we start with androgen deprivation therapy, which can be LHRH agonist or antagonist or androgen receptor blockers, or alternate if the disease is progressing, combined androgen blockage. If non-metastatic castrate-resistant prostate cancer, still we continue with this patient with androgen deprivation therapy and try the other endocrine manipulations. In metastatic castrate-resistant prostate cancer, bone mets, we start with the zoledronic acid, and we have the option of giving them palliative radiotherapy if they become symptomatic. And if they're symptomatic and disease is progressing, we start with the docetaxel chemotherapy, that's the first line, or we can enter them into the clinical trial. And if they are symptomatic, we still start with the docetaxel chemotherapy as a first line, and or can be given within the clinical trial. Post-docetaxel, this is a new development from June 2012, and the Abiraterone was approved by the NICE. So that's the next line of the treatment available now. And as an alternate to that one, if patient is not able to have that one, docetaxel re-challenge, which we have been doing in the past, although with added toxicity, or within the clinical trial. Cabazitaxel is another third line or second line we can say about. But this drug is available in England with from the drug fund. It's not approved by the NICE. And in the Wales, through the IPFR route, this drug is available, but hardly we use that one because I think availability plus the toxicity of this drug is quite a lot. Just going back to how the standard developed, is first of all, as we know, the landmark trial was a text 327 and SWOG 9916. In this first text 327, it compared docetaxel 3 weekly with the weekly docetaxel and mitoxantrone along with prednisolone. And in this, it showed that was the first real change in terms of chemotherapy, because before that, the prostate cancer was thought to be resistant to the chemotherapy. And that showed a change, gave an overall survival benefit of 2.4 months as compared to mitoxantrone with 3 weekly docetaxel. Similarly, the other trial with docetaxel and exemestane also gave the survival advantage, but that have more toxicity as compared to docetaxel on its own. So that's why the docetaxel became the more standard of the care. And in 2006, this was approved by the NICE, and so that was a real change after 1996 when mitoxantrone was started to use, and after 10 years of gap, this was the first change. Then this recently, this Abiraterone, which has shown a good overall survival benefit within this trial, COUA301. It was a phase 3 trial in which Abiraterone was randomized 2:1 with Abiraterone acetate plus prednisolone was compared with placebo with prednisolone. And a quite good number of 1,200 patients was enrolled into this trial. And the basic outcome of this trial was there was a significant overall survival benefit, which was 10.9 months with placebo, while it was 14.8 months with Abiraterone at the midterm. And the toxicity profile was very well tolerated, although few side effects, which I will tell you later on. So this is briefly about about this trial. That's median overall survival in Abiraterone was 14.8 as compared to placebo 10.9. Time to progression and progression-free survival, PSA response rate, all were very statistically significant. How this drug works is that this drug blocks the this blocks the enzyme 17-alpha hydroxylase, which is involved with the conversion of pregnenolone to 17-hydroxypregnenolone, and which in turn converts into dihydroxyepiandrosterone, and which lead to testosterone. So when this is blocked, that lead to increased conversion to deoxycorticosterone and corticosterone, and when their level increases, that leads to hypokalemia, hypertension, and fluid overload, which is one of the known side effects from this drug, and which we monitor for these patients on a regular basis. But so far, what we have seen with the practical experience, this drug is very well tolerated, and hardly we have seen any patient who has come across with these side effects. So now we talk about the drugs which are in the pipeline at the moment and or coming up on the horizon. This I've taken it from the American, how the FDA has approved over the line. In 1984 to 1989, LHRH agonist came up, and then a real change was the mitoxantrone in 1996. Then zoledronic acid was approved in 2002 by the FDA. Docetaxel in 2004, and then after a big gap of 6 years, cabazitaxel, sipuleucel-T, and denosumab was approved in 2010. And Abiraterone was approved in 2011, and it was approved in 2012 by the NICE. MDV 3100 is approved last year, and it's not approved over here as yet. And radium 223 is going through the fast track in approval by the FDA at the moment. This is a small, brief, I think it's a little bit complicated cartoon. I tried to put all the drugs over here so that just to give you a quick glimpse of the drugs, how they and where they work it. I start from the one corner that's XL184 that inhibits a c-Met, which is involved with the increased angiogenesis, proliferation, and motility, and that not only on the cancer cell, also on the osteoblast inhibits. Then another drug in the osteoblast is dasatinib, which inhibits the SRC, which is involved with, again, more differentiation as well as proliferation. Then is that dasatinib also inhibits in the osteoclast as well. Then going on to the right corner over here, I think this is not working very well. The bevacizumab, sunitinib, and thalidomide that has been tried within the in a trial combination with different drugs, but so far they have not shown any great promise so far. Then comes the T cell, which is the immunotherapy. Out of that immunotherapy, sipuleucel T has shown quite a good promise, which has shown a good overall survival benefit. And other Prostavac and ipilimumab is at the moment within the trial phase. Then going into the cancer cell on the top over here, CYP17, that's an androgen biosynthesis inhibitor, abiraterone and TAC700 inhibits the biosynthesis of dihydrotestosterone. Then cabazitaxel and docetaxel inhibits the microtubule in the cell and decreases the cell division or inhibits the cell division. OGX011 inhibits the BCL2, which is involved with increased proliferation and division. Okay. Now going on to the few trials about those drugs, which I've briefly outlined previously. First one is within the about the cabazitaxel within the TROPIC trial. It was a phase 3 registration trial, and it has quite a good number of 755. And it was randomized between cabazitaxel with prednisone versus mitoxantrone and prednisone. Primary endpoint was overall survival, and secondary endpoints were progression-free survival, response rate, and safety. And this drug has shown that median overall survival improved from 12.7 to 15.1, and with a hazard ratio of 0.72. And with a statistically significant p-value. Due to the shortage of time, I have not gone into the detail of that toxicity and side effects of that. Then the next drug is sipuleucel T. It's a sort of immunotherapy, and it involves quite a complicated way of giving this drug. This is only at the moment used in America, but it's not used in Europe or approved over here, because of the cost and sort of a lot of complications. Setup is required for delivery of this drug. But this drug has shown overall survival benefit of nearly 4 months as compared to the placebo. Then this is the trial drug which has gone to the phase 1 and 2, which is the dose and differentiation study. TAC700, which is similar to abiraterone, and that has shown a 53% with PSA decreases. It happens in more than 50% of the patient at 12 weeks. And the other plus point of this drug is this drug can be given without or with or without the steroid. Then another very promising drug is enzalutamide, which is in the AFFIRM trial, and which was again a phase 3 trial. And it was randomized 2-to-1, in which enzalutamide was randomized against a placebo. About 1,200 patients. Primary endpoint was overall survival, and key secondary endpoints: PSA response, soft tissue objective response, radiographic progression-free survival, time to PSA progression. And this drug has also shown a very good statistically significant overall survival benefit. 13.6 months with the placebo, as compared to with enzalutamide, it is 18.4 months. and the tolerability profile for this drug is also very good. Then another very targeted treatment is cabozantinib, as I showed in the initial cartoon. Also called XL184. This drug inhibits MET and VEG receptor 2. And MET basically pathway promotes tumor growth, invasion, and metastasis. And overexpression of MET and our ligand, human growth factor, are associated with prostate cancer metastasis. In preclinical studies, androgen ablation upregulates MET signaling. And this drug has shown high rates of bone scan improvement, reduction in bone markers, regression of soft tissue disease, progression-free survival improvement, pain improvement. So all the parameters has improved with this drug in the phase 2 trial. Some of the basic characteristics in the phase 2 trial. And it's about again, it's important. Some of the whatever they found out from the phase 2 trial was that there was 67% complete or partial bone scan responses, 80% regression of the measurable disease, 46% median pain improvement in patients with pain score less than 4, 56% decrease of discontinued narcotics, activity regardless of prior abiraterone and or cabazitaxel therapy. And there were manageable adverse side effects from this drug. At the moment, that's a phase 3 trial has been set up for this drug. At the moment, currently in States, not here. Comet 1 and Comet 2. In the Comet 1, cabozantinib is being compared with prednisolone, while in the Comet 2, cabozantinib will be compared with mitoxantrone and prednisolone. And this is again a few of the diagrams which has been taken, those patients who has taken this drug. And if we can see on one side, on the right side, that's a patient, there's a bone scan after the treatment of 12 weeks, which shows quite a significant bone scan improvement. And similarly, there's an improvement in the symptoms as well for the patient, control of the disease. And over here, if you see the progression-free survival graph over there, which is quite a wide gap between the placebo as well as with the cabozantinib. Another promising drug which has shown a survival advantage is radium-223. And as we know that when the radium belongs to the same class of as the calcium is, and it is preferentially taken up in the bone. And radium-223 is alpha emitter, and the alpha emitter has more number of damages more cells in the surrounding, in the vicinity, rather than to more at a distant place. And so that's a big advantage of this drug, that it will target the disease more in the bone. And this drug was in the L-SIMCA phase 3 trial and has shown overall survival of 14 months as compared to 11.2 months. And the tolerability or side effect profile is also good for this drug. Then another update about that abiraterone in the chemotherapy naive patients. In the ASCO 2012, they presented a double-blind study of 1,088 patients in which abiraterone plus prednisolone was compared with placebo versus prednisolone. And the interim analysis, which was presented in ASCO 2012, it showed that the median radiographic progression-free survival was 16.5 versus 8.3. And there was initial assessment was that there was a trend towards improved overall survival. And later on, this was unblinded as there was a benefit for these patients, so all these patients are now getting this abiraterone. So at the moment, this is hopefully in the next 1 or 2 years, possibly might be approved as a chemo-naive patient. This drug can be given. This just to summarize. I've summarized all the trials which has shown overall survival benefit so far. And out of that, the more I will say is MDV 3100 has shown the most survival benefit, which is nearly about of 5 months. which is quite significant. This is a very also interesting slide, and in which if initial stage androgen-dependent tumor, when it progresses to first initially tumor response and it regresses the tumor, then androgen-independent tumor becomes, and the PSA initially is high, then goes down and then goes up again as the tumor becomes resistant. Similarly, the androgen receptor also follows the same way as the androgen PSA follows. Then the other genes which has shown interestingly that the PTEN goes down as the disease becomes castrate resistant, while the other genes PI3K, MAP kinase, BCL2, EGFR, PDGFR, cholesterol and heat shock protein 27, they all go up. And these are all at the moment in different trial for different drugs being developed to whether there is a benefit in terms of control of the disease. As a whole, there's multiple now drugs which has shown the overall survival benefit: docetaxel, abiraterone, cabazitaxel, MDV 3100, radium 223, and cyclobutyl T. And new targets are coming up, new targeted agents: cabozantinib, OGX011, TAC 700, and dasatinib, and with immunomodulator ipilimumab. What I think in the coming few years, what the landscape will be, how these drugs might be used, that still in the hormone-naive patients, androgen deprivation therapy will be the standard of the care, and later on combined androgen blockade. Non-metastatic castrate-resistant prostate cancer, more likely these abiraterone and enzalutamide might come as the first line rather than the docetaxel chemotherapy and other endocrine manipulations. With metastatic castrate-resistant prostate cancer, bone mets, we will use denosumab. At the moment is not approved by the NICE, but is approved by the FDA, but hopefully in future it might be approved. Because in the head-to-head trial, when they compared the denosumab versus zoledronic acid, all the parameters were better as compared to zoledronic acid. Radium 223 will come into this jargon, and currently what we are using, zoledronic acid and palliative radiotherapy, will still remain. For asymptomatic patient, again, abiraterone, enzalutamide, and cyclobutyl T, whether it comes over here or not is a question, and still docetaxel will be an alternate for that. For symptomatic patient, still I think the docetaxel will remain the treatment of choice for that. And at the moment, docetaxel is being trialed with different combinations, and if those different combinations showed any benefit, so that might be the future that the docetaxel might be given in combinations, or can be given within the trials. The post-docetaxel, we will be having more further options with abiraterone, cabazitaxel, enzalutamide, or clinical trial. And third line, same, if we have not used previously, that can be used subsequently. So plenty of options are available, hopefully in the coming few years. And how we can then use them, just have made a brief flow chart. Everybody can disagree with that one, but I think the main thing what will happen is we need to maintain the castrate level of the testosterone with the LHRH agonist and antagonist, and we'll give them use either denosumab or zoledronic acid, and to give them vitamin D and calcium for all these patients. And then depending upon whether it's a symptomatic or visceral disease, if it is not, or patient is not fit for chemotherapy, then the abiraterone, radium 223, and enzalutamide, dexamethasone, or clinical trial will be more likely the sequence, or not the sequence, available options. But if the patient is fit for chemotherapy and is symptomatic or visceral disease, chemotherapy docetaxel will be the number one. Then others, abiraterone and enzalutamide, and others will be the further, which we can jargon around. Then the future direction again is not very straightforward. It will be a bit complicated in a way that how we can make a sequence of and what sequence we can be using these drugs. and whether we will be using in combination or combination will be more better or not. And more targeted treatments are coming up, and their efficacy, just like enzalutamide, is also showing a very good promise. And another, like a personalized treatment with like gene testing and gene which patients are going to respond to chemotherapy and which are not going to respond. And similarly, the cross resistance, that's another issue, will be that if we have given taxane first and those patients will be responding well to abiraterone, or if we have given abiraterone first and will they be responding very well to the taxane as well. So similarly, all those drugs, it will be whether they develop cross resistance or not, the time will tell about that. And briefly about the skeletal related events, I think Nigel has explained about very well in detail. But again, the timing and of the bisphosphonate is important. We need to start that bisphosphonate very soon, when we have started with the LHRH agonist or antagonist, and we have found the bone metastasis for this patient. And denosumab, hopefully, if that approves, then that will also come into the jargon as well. And thank you very much for that. Any questions?